Hello and welcome to JNO Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open. Of course, if you're following along live, please send us your questions or comments on YouTube or Facebook in the comment section or on Twitter at JAMA Network Open. Today, we are talking about U.S. clinicians' experiences and perspectives on resource limitations and patient care during the COVID-19 pandemic. And we've got first author, Dr. Catherine Butler with us. Welcome, Dr. Butler.
Hi, thanks for having me.
Great, really glad you could join us. If you could just tell us a little bit about who you are, what kind of work you do, and why you did the study here.
Sure. Well, I'm a nephrologist, an acting instructor at the University of Washington, and also a research fellow at the VA Health Services Research and Development. And I also have a background in bioethics. So my research interest recently has been in the selection and evaluation process related to kidney transplant, which up until recently is one of the only explicit examples of resource allocation we have in this country. So you can imagine that it was a bit of a surprise for someone who's worked on these issues more in theory to suddenly see resource allocation and triage being pretty prominent, not just in the medical literature, but also in the popular press. There's a lot written on this. There's a lot of theory, but unfortunately, the COVID pandemic presented a real life test of our theory on how to appropriately allocate resources. So we were interested in that, and that's why we did this study.
Sure. So you did this nice qualitative study. Tell us just a little bit about what you did and what, most importantly, what you found here.
Sure. So we interviewed 61 clinicians of all different backgrounds across the U.S. In the first 2 months of the pandemic. And before I say more, I should say I continue to be incredibly appreciative of these clinicians for taking, an hour of their lives during a really busy time to talk to us and participate in this study. But we tried to get a broad scope of perspectives. Most of the clinicians we talked to were practicing in some of the harder hit parts of the country. And we did a qualitative study. Hopefully some of your listeners are more and more familiar. But the idea of this kind of study is to answer questions like, how does something happen, or what is something like? So after we did all these interviews, we looked for emergent themes that kind of described clinicians' practice around resource limitation during the COVID pandemic. And we found that first, there was a mirroring of kind of a national plan to come up with triage teams in crisis capacity. But even early on, we were sensing that these clinicians who were part of institutional planning were finding kind of barriers to translating practice or policy and theory into practice. And then despite the fact that all the clinicians we talked to mentioned that they hadn't actually had to resort to this crisis capacity setting, they were still encountering what could be really distressing need to allocate resources at the bedside. They were incredibly creative about coming up with other kinds of options and treatments for allocating resources, stretching resources thin. But it did mean kind of pushing the boundaries and sometimes offering treatments that were highly risky and certainly not aligning with the plan to offer what the Institute of Medicine has called functionally equivalent to standard of care treatment up until crisis capacity. So overall, what we found was that this kind of stepwise approach that our community had been planning to use if we did reach crisis capacity really wasn't reflected in the experiences of clinicians who are facing resource limitation in the real world.
Yeah, that was actually one of the things that really resonated with me. I'm an emergency physician, and in Chicago we got hit pretty hard. Not quite as hard as New York and Detroit and some other places, but it was pretty bad during that first big wave. And one of the things that really resonated with me out of the paper was how, despite the the kind of conceptual framework of the 3 different phases that you can see in the figure. It was really more of this spectrum. And, just little things that you don't even think about. Like we couldn't use a non-invasive positive pressure ventilation for fear of aerosols, and, figuring out ways around it. Like we used epinephrine sometimes for asthma, which I haven't done in, years, basically. And just as one of the respondents put it, the word that struck me a lot was squishiness. It wasn't clear.
Squishiness, I liked that too. That too. Yeah. And you mentioned one of the other things that came up as kind of a last theme in our analysis, that when you're thinking about what is an appropriate standard of care, and when have we hit crisis capacity, it's not just resource allocation that impacts standard of care and what you're able to offer to patients. It's also those other things like you're suggesting, having to avoid aerosols, having to avoid contact and things like that. So just one more wrench in this kind of theoretical plan.
Yep, absolutely. Similarly, I think I just like pulling quotes out of these kind of studies because it's
right.
So great, but that everybody gets a little bit of bad care, that so much of it isn't we're not doing X, or we are doing Y for these two patients, these choices, but just the little choices you make all the time. And I think to me too, that also stood out as something that's almost not new necessarily. Like, I'm at a big urban academic center, our ICUs are always full or close to it. It's always a question of which patient is really going to be the next ICU patient or wait in the ED for hours.
Right. That kind of quote is really heartbreaking. Clinicians are really trying to do their best. And ultimately that, in this case, that meant, since there wasn't really any other guidelines, spreading things thin in some cases. They knew where they weren't giving the kind of care that they wanted to for patients, but again, they were doing the best they can. And some of the interviewees actually did mention that this kind of makes them think about how we approach limited resources in settings outside the COVID pandemic. And like many of the lessons I hope we're taking from the pandemic, I expect that this will be one more that will kind of look at fiscal resource limitations and other resource limitations a little bit differently after this experience.
And not just, I don't want it to be all negative. One of the things that I appreciated, and I think that came through with a lot of the responses, was how, following the IOM guidelines, or was trying to make it so there were protocols, so it wasn't clinicians at the bedside making these decisions, which is just lofty. And the amount of planning, the number of triage teams, the number of protocols that were developed, I think helped reflect the kind of efforts. There were, of course, a lot of barriers there, and a couple of the exemplar quotes that were unfortunately much more pessimistic, but that I think I both appreciated that in real time, and again, it resonated reading your paper, how much of it was trying to make it so it's not Dr. X choosing between patient A and patient B.
It is, and that's something that I've found really heartening about watching the publications around this area in again, the medical journals and the popular press. There's been a lot of interest in coming up with a practical way of a practical and fair way of allocating resources that takes this burden off of clinicians. The problem, it seems, is that the structure that we've come up with is maybe more in line with our past experience with wartime triage or mass casualty triage, where it's very clear that there's a certain set set number of resources and a certain group of people that we have to decide between. But the pandemic has been smoldering and kind of ambiguous whether we've hit crisis capacity sometimes. So I don't think that we should throw out all that great planning that folks have done. As you say, it's been really valuable. But I wonder if there's also a kind of intermediate zone where we need to be a little bit more creative in how we support clinicians.
Yep, absolutely. I think that ambiguity you're talking about really, again, resonates, where, I remember during the thick of it, every day I would start off my shift by going to the charge nurse and apologizing. But, I'm going to ask you again, what are we doing today? Who are we testing? Who are we admitting? Where do we admit people?
Right.
There's the information overload, and the change behind it was just so huge, and just the kind of adaptation all the time.
Right.
And as you described, the multiple unprecedented barriers, the little things you don't think about, where we have tests, but we don't have enough swabs to do the tests, or we're anticipating we're going to run out of swabs, or things like that.
Right, exactly. And I think One more thing that made the situation all the more blurry, just to relate it back to how people were thinking about resource limitation, is sometimes it wasn't clear whether those new policies that were changing all the time were based on limited resources or based on trying to limit contact or some other change in our practice or justification for our practice during the pandemic. And sometimes it wasn't, no one knew. And sometimes that justification was changing. So again, a reason that it was difficult for folks on the ground to really make decisions.
Yeah. And I think just to riff on that little bit, some of that I think was fortunately the different motivations for new policies were aligned in similar ways. Like when we were initially trying to avoid intubating patients, or again, not in the kind of second part of the first wave, as we started learning more about keeping patients off ventilators, it was great because we could both avoid ventilator use because ventilators were going to become more limited of a resource, and also avoid the potential 3 weeks of a patient being in an ICU ventilator, which is obviously a important patient-oriented outcome, the complications that go with being ventilated. But then it became an issue of where high flow oxygen was great, but those resources were limited themselves.
Right.
I remember a couple of patients where it's we're in a gray zone of should we start a patient on high flow, but now is it good to start them because we might avoid intubating them, but then it's a close call because now we're using this limited high flow resource.
So difficult, and what was limited was very day by day. And some of the interviewees were talking about how they would suddenly be faced with a supply or something like that was limited, and then have to kind of troubleshoot that. We planned for ventilator and ICU bed shortages, very discrete. Well, I guess you could argue that as well. And
more discrete.
People came up with more discrete. Let's say more discrete. But the structure that we came up with really does kind of rely on resources being discrete and it being apparent if it's there or not. But some of the things you're talking about, and then, as a nephrologist, I kind of keyed into and experienced more of a limitation around dialysate and time on dialysis. How do you draw a line there in terms of what's appropriate and not?
Mm-hmm. Yep.
Yeah.
I know we're going a little long, but one thing I want to get into a little bit because there were so many good comments was about getting palliative care involved or not. And, fortunately, in the ED that didn't come up too much, and there's a whole thing we can talk about whether or not we should be getting more palliative care involved in emergency medicine. But I feel like it was really interesting where there's I think some of the things that you described really well is one is the fear of appearing like people are rationing or choosing to hasten natural death, and then but also what on the plus side we learned a lot of patients who but for COVID would look pretty like they were getting futile care, but then the average length of stay at first was something like 21 days in the ICU or something like that. So it's very atypical. I know it just seems like so many things went against our instincts.
There's so many complex and conflicting values there, and kind of how we thought of palliative care before this, and what the public's reaction to the perception of entering a hospital and potentially being subject to rationing. Very complex, but I agree. A lot of the comments that came up about how people were interacting with palliative care were a bit surprising, and really showed some of the difficult kind of struggles people were having. I agree that I think there are one or two quotes that might be cited in the paper, but this idea of avoiding palliative care consultation because there was a concern about being perceived to be rationing was quite heartbreaking. And I think, again, if there were some more structured way, a more kind of accepted approach to what rationing looks like and when it's acceptable, maybe we'd be able to help those clinicians make that kind of decision.
And it was again the so many comments about wanting to avoid the appearance of rationing when we're basically rationing all the time. It's not always a prank.
Well, I mean, yes, that's my belief, and at the same time, it's almost hard to call it rationing if it's all the time. I think maybe the answer to this is that the real world is more blurry, especially for clinicians. Yeah.
Yep.
I guess I'll leave it at that.
I feel like we usually know another 2 hours on whether or not we ration.
Right. And I'm willing to.
All right. Well, next time, looking forward to the next paper so we can have you on again. This has really been a fantastic discussion. I think the paper is really great as somebody who unfortunately, worked through it and is unfortunately anticipating seeing this become relevant again as our numbers are getting bad and we're reaching the limits of our typical resources. But thank you again, Dr. Butler. This is a really fantastic paper, which of course everyone can get at jamanetworkopen.com, where it's free and open access. We have new papers coming out every weekday at 10 a.m. Central Time. Join us next week, November 17th at 3 p.m. Central Time again for another episode of JAMA Live. And of course, stay safe and take care. Thanks again.
Thank you.